I know that face. Good morning.
Good morning, Carolyn.
It has been a long time. Hope you had a great week. I had a great couple of weeks, still walking into walls, trying to acclimate back. Nevertheless, very happy to see you so much. And I'm going to welcome everybody in that's coming up. I know I got a lot of posts saying, when are you guys going to be back? And here we are. So I'm going to get started with question number one. What do you think?
Sounds good.
I keep moving around. Okay. Number one, Dr. Rosensweet. A woman goes 11 months without a period, and then she gets a period. Does this mean that she is still in perimenopause? And also, how long can a woman be in perimenopause, and how does one treat it? This woman says, I hear it can last for years and years, and it's miserable. Thank you.
Yeah. I'd like to revise how we think about perimenopause. Just
Okay.
to get, and really, we're talking about hormone decline over the ages. And it all begins with human beings. We put our most prolific ovarian or testicular hormones at the age of 20. This is the highest output, plus or minus a couple of years. And from that moment on, these hormone levels decline till the day we leave Earth. The decline continues, marches on in men and women. There is a little bit of a difference there. Women have a precipitous fall off, not a total fall off, but women are declining, and then around midlife sometime, there's a major decline, and those ovaries stop producing. In a male, but that's what happens in women. Those ovaries stop producing. And, that's dramatic enough that there's not enough estrogen to form a lining to the endometrium of the uterus and thus menstruate. So a woman stops menstruating. And that's dramatic. But the thing that is biologically most significant to a woman is the hormonal decline, which begins at the age 20. Now, from the ages 20 to 30 for most women, or 35, the decline is not that significant. And even though the decline is occurring, there's still plenty of estrogen, progesterone, testosterone, and DHEA coming out of that ovary that very few women notice that decline. Some women do. That decline can be significant enough that some women in their early 30s or mid 30s are getting symptoms from the decline. One of the most common things that happens is, although you'd think estrogen and progesterone, not to mention testosterone and DHEA, I'm leaving them out right now, you'd think they would decline at the exact same rate. Well, they don't. What's very common, not necessarily biologic or physiologic, is they decline at different rates. The progesterone declines more significantly, deeper decline, earlier than the estrogen does. So although ideally estrogen and progesterone remain in balance throughout the decline, if that progesterone declines earlier and deeper than the estrogen, there's a gap that widens there. And these two hormones are balanced under ordinary circumstance. And if the decline of the progesterone is earlier and deeper, that imbalance leads to a predominance of estrogen related functions. Estrogen stimulatory. Estrogen stimulates breast glandular tissue in preparation for possible breastfeeding once a month. Estrogen stimulates the production of the uterine lining. If that stimulation is not balanced by proper progesterone, you get overstimulation of estrogen in the breast, so you get breast tenderness, and some biologic changes can even take place towards dense breasts, cysts, etc. And in the uterus, you can start getting uterine cramps and heavy bleeding because the progesterone is no longer balancing the estrogen. So, with all those moving parts, lots of different things can happen to a woman. Now, we like to say, oh, she's in the perimenopause, as if that were one thing. It's not one thing. It's a general term used to describe when a woman's starting to get symptomatic from these declines and imbalances. Some women don't even experience a perimenopause. They're just cruising along, period stops, they go into menopause, bam. That's not too common because the declines are pretty universal and the imbalances are pretty universal. So more often a woman in her 30s can experience mild, moderate, or rather intense symptoms of both decline and imbalance because both are taking place. Maybe the imbalance will prevail in the 30s and 40s, in quote, perimenopause. Maybe the decline of both will prevail. Maybe a combination, because you start getting declines in estrogens, you can start getting a little cognitive issues, or you can wake up in the middle of the night with a hot flash. You're still menstruating, but you've got a hot flash because you don't have enough estrogen. Symptoms are possible. You can start getting vaginal dryness. A woman in her 30s can start needing lubrication on intercourse, where she didn't when she was in her 20s. That's from good estrogen primarily. So you can get symptoms and signs of these declines in the quote perimenopause. Now, menopause has a very specific definition by gynecologists, and I think it's a valuable definition. They say a woman must be 1 year without her period to declare her two things: in menopause and no longer vulnerable to getting pregnant if she doesn't want to. 1 year without a period. That's officially menopause. Why is that important? Well, your questioner described the scenario. She went 11 months. Oops. By definition, she's not in menopause. But that doesn't, these distinctions, these language distinctions are only so valuable. I like them. They give us a context and a general understanding, but they're not precise. No problem. In clinical practice, this is not a problem, whether she's in menopause or perimenopause. This woman who didn't have a period for 11 months has got some awfully low estrogen and progesterone. It's highly unlikely she's got any progesterone to speak of because her periods have gotten so irregular that it's very unlikely that she's ovulating. How do you know if a woman's ovulating? Well, you got a pretty good bet that she's ovulating if she's got clockwork every 28 or 27 or 29 days. Periods. Clockwork. When she goes unclockwork, uncalendar, on moon calendar, she's irregular, and the likelihood that she's not ovulating, that's not producing progesterone, because you must ovulate to produce substantial progesterone. So there's a lot of moving parts, and they really don't matter. The moral of the story, well, this woman who hasn't had a period for 11 months, officially, there's a chance she could get pregnant. How likely is it that she could get pregnant? Whoa, very unlikely.
Happens.
11 months, probably didn't ovulate. Very unlikely that she didn't ovulate. Almost certain she didn't ovulate. If you don't ovulate, you don't get to get pregnant. However, gynecologists say 1 year for a reason. Because if a woman's gone 11 months, there's a one, I don't know what the chance is, 1 in a jillion, that she still could get pregnant. So fair enough. That's something worth defining. The likelihood is low, but it's still there. So that's why they're all inclusive in that definition. 1 year without a period, you're not in menopause until you go 1 year. Now, are your hormones low? Is it very unlikely that you haven't ovulated if you're missing a couple months? Whoa, your hormones are low. Now, the clinically relevant situation here, well, there's always the consideration of, can I get pregnant? Is birth control necessary? So everyone's got to sort that one out for themselves, because the odds change. A 28-year-old woman who has clockwork regular periods, man, she can get pregnant. High likelihood, like up there, way up there in the high percentages. A 40-plus woman who hasn't had a period for 11 months, the likelihood of her getting pregnant is very low. But I'm mentioning this just for completeness, because if you haven't had a period for 11 months, you can't still guarantee yourself that you don't need contraception. Very unlikely, but the main thing is your hormones have been declining. And of course, we are strongest 100% advocates of replenishing hormones in males and females. We've got the opportunity. I know there's many people who think life is natural and that better to just go it with, without any hormones. Yeah, talk to a lot of women and men. Talk to a man who's lost his erection and say, we think you should go it au natural and don't take any hormones. Talk to a man who's in a relationship and he's not getting an erection.
Oops.
See how convincing you're going to be. You
No,
should go natural. Aging is natural. You don't need your erection anymore. Yeah.
not.
Yeah, that's not what Viagra revealed to us. That men care about this erection rather dramatically. Talk to a woman who can't sleep at night, and she's gone 3 nights because she's woken up with night sweats and she's staying awake for a couple hours, and she's hasn't slept for 3 nights. Tell her, go on natural. It's a good thing. It's just the natural aging process. There's a lot of things natural about human life, but there's a lot of things that are not fully perfected and thus not natural in the least. I'd like our audience to assess, for example, how many thoughts did you have yesterday that were not natural thoughts?
I have mine written down right here. But we'll get into that later.
You thought they were natural thoughts, but they weren't.
You're right.
They were stories you were telling yourself,
You're so right.
and you thought you were making assumptions about reality, and you thought those were real, but they weren't. I'm not talking about you. I should say we.
Us.
And then we make decisions and choices. Now, is that a natural life? And then the decisions that and choices we make out of these stories that aren't actual perceptions, not natural, not what's actually going on, can lead to very stressful situations, trigger the fight or flight biology, beat up our bodies, overdrain the glands, suppress the immune systems. Oh, God. So talk to me about natural, please, when we're far more enlightened than the human race seems to be enlightened at this moment in history. 2022, extremely primitive. Look what's going on the planet. Now, perhaps you're not a part of that, but so I know I'm drifting a little bit here.
No, it's okay.
So we're 100% advocates of replenishing hormones. Haven't run into an exception yet.
Well, if a woman, she's confused because out of nowhere, she thought for sure, you know, okay, I'm menopausal now.
Yeah.
What does she do? Does she take
Well,
hormones?
the only thing that matters is a decision around contraception, because she's not, the likelihood is so low. I'm mentioning that just for completeness. You want my opinion about, we should take hormones as early as we can possibly identify hormone depletion that's life significant. So if a woman's been basically happy and in her 40s she starts developing anxiety out of the blue, but she doesn't know where it's coming from. Yeah, there's stresses of life, but she didn't really have anxiety or depression, or she's not sleeping well, or she's got breast tenderness or uterine cramps that she never used to have, or skin's drying, or vagina's drying. A long list of symptoms that Carolyn, you know this so well. You posted a free PDF copy of our book. We list those symptoms, and there's a long list of them. Why is there such a long list? And why are these such profound problems that develop? Because hormones are the most powerful biochemicals in our body, and when they're not there, it's highly consequential. So I say replenish it at the first hint. Having said that, we start treatment with some women in their 80s. They haven't had hormones for 30 years. It's always an individual by individual decision. In other words, it's never too late. And we have proof of that with my mother and my mother-in-law, for example,
And the videos.
the videos thereof. However, my best advice and recommendations for men and women is when you start getting when a man starts waking up and he doesn't have the morning erection that he had when he was 18 or 28. Oh, look at that. I don't have that very often. That man should start getting evaluated. The earlier the better. Just something as simple as that. He has intercourse fine. He can maintain an erection, but that loss of that morning erection is a sign that his testosterone is declining. When's the best time to treat him? Right out of the gate. That doesn't mean we wouldn't start treating a man who's 70, who hasn't had an erection for 10 years. I'm
But
not
you
trying to
have,
say that it's ever too late.
right.
But the ideal time is like once I started hearing a sound in my 15-year-old automobile, and I started noticing I was burning oil, and I knew what that meant. And then one day I'm driving down the interstate and smoke starts pouring out from under the hood.
Oops.
Better I should have gone, I'm hearing this sound and I'm burning oil. I think I better take this in and get a motor check here from my mechanic. No, better you should. And the same thing for us, better when a woman's waking up and she used to sleep well. Now she's not sleeping well and she's waking up for a couple hours. She's got a warm rush or maybe not, but she's got a racing mind when she wakes up. Well, that's the ideal time for us to interact with this. She still could be menstruating. She said, I couldn't be in perimenopause or menopause because I'm still menstruating. And that's why I'm trying to blur the distinction. It doesn't matter. You're getting hormonal decline. When that hormonal decline becomes biologically important, you're losing function, you're losing muscle because you're losing your testosterone, you're starting to get flab under here. This is one of those instances in medicine where an ounce of prevention, i.e. early intervention, is worth 82 tons of cure. Yeah, we can get things back, but not the longer you wait, the more challenging it is. So you lose a lot of bone, lose a lot of muscle. Are you going to get that muscle back when we replenish testosterone? Are you going to get that bone back when we replenish the estrogens and the testosterone and the DHEA and the progesterone? Maybe. But we don't want to hear maybe out of a dump. We want to hear, yeah. So the earlier the better. I don't know, Carolyn, I've sort of lost sight of what you
No, it's fine.
you
She just got scared, I guess. She got her period after 11 months and she's frightened that now she's still in peri and she doesn't know what to do. And
Yeah, but the words don't matter. There's only one other thing to consider. This got my period after 11 months of no period is a common thing. let's go interview the next 100 menopausal women that we run into, and you can bet some of them, they were just startled. They got a period after 11 months. So no worries about that, and no need to define perimenopause or menopause except to make that rare decision around contraception. But occasionally there's something not okay there. Rare. That bleeding is not really a period. It's really coming from an abnormality inside the uterus, even endometrial cancer. So we live in a day and age that if you're willing to go to a good gynecologist, this is all covered. They know just what to do. They know how to evaluate it. They do a simple, non-invasive procedure, relatively non-invasive procedure called a transvaginal ultrasound. And they see, is there a fibroid there? Or is there something less okay that they want to take a biopsy of? So occasionally that 11-month bleeding is that rare endometrial cancer. But, I wanted to go this whole lifetime without ever needing to go to a doctor or a hospital. That was my goal. I'm a doctor. I had a goal of never wanting to go to a doctor or a hospital. Well, lo and behold, I have changed my mind. I am so grateful when I have needs and my physical body has got some challenges. I'm like every other human I've met, most every human. So we want to celebrate that no matter what your opinion is of the medical profession, there's a lot of good doctors out there.
Oh, indeed.
Caring, knowledgeable, experienced. Okay, not all have the best bedside manner, but you're not going to them for their bedside manner. You're going to them for their genius. Man, gynecologists have great training, and they know how to deal with these things.
Yeah, and it's
so
not exactly
I have my own bevy of go-to physicians when I have health issues. I made an appointment yesterday to go see one of these specialists. So I've surrendered. Dr. Natural has surrendered.
Dr. Natural has surrendered.
And has deep gratitude for what modern medicine has done for me and my family and my beloved family and my friends. Deep, deep gratitude. So don't throw out the baby with the bathwater because you don't necessarily like some of the practices or the people. We're human. It's not perfect. But my God, the training programs that specialists go through in this country, they're awesome. And they lead to a level of experience. So you go tell a gynecologist, hey, I'm bleeding. They know just what to do. Right down to treatment. If it's the worst case scenario, they know what to do. And you catch it early. So I know I'm going in many directions here, but I'm a human being that has surrendered to the gifts we're given in 2022. We got medical expertise out there that can really serve us.
We do indeed, and I share your gratitude. And well, you're a doctor, and we surely appreciate you. And hearing you say that you're not exactly thrilled with going to the doctor, I
Yeah.
can't even imagine.
Yeah, how many of us would just love to go to a doctor's office or a dentist's office today?
Oh, dentist, yes, love that.
Just, it's not, we can probably think of other ways we'd like to spend our time and money. So I understand the resistance.
But the payoff is almost
The
always
payoff,
a good one,
yeah.
you know? Okay. Well, thank you. Thank you for that. Um, moving on to question number 2, comes in. Woman says BHRT makes me feel great, and I do not ever want to go off of it. Prior to, I had no quality of life at all, but my paternal grandmother did have ovarian, breast, and uterine cancer. I do not have the BRCA gene. But I do know, however, the risks for these cancers is increased for me by taking BHRT, but by how much? I'm a little confused here. Can you expound on that?
Yeah, thanks, Carolyn. There's an incorrect statement in her question. There's concern, but there's an incorrect statement. My risk is increased by taking BHRT. That's the common perception because of an egregious medical error that occurred in 2002. A medical misstatement that the press got a hold of and went wild with. So there's an egregious error in there. That's not true. Your chances of getting these cancers is not increased.
And so many people
The
think so.
science tells us that. Now, this is a tremendously hot topic. It's the most bizarre thing I've ever seen happen in my many years of being a physician. Misinformation came out that had tremendous adverse impact. The misinformation was that hormones increased a woman's risk of breast cancer, heart attack, and stroke. That was wrong information. It happened to be the opposite of what's scientifically so. But what got published in the press and screamed the world around was that women were at increased risk. That was false. It was even false in the study that the press got a hold of. Well, they didn't get a hold of it. The committee that produced the false report held a press conference a couple of weeks before they published the article. So there was no to see all the missteps that took place there, and the adverse impact is outrageous. And in the original report that scared everybody, the Women's Health Initiative in 2002, they even said that there was a reduced risk for breast cancer with Premarin, horse urine-derived estrogens. Reduced risk. Women who were treated with Premarin were at less risk for breast cancer than women who did not receive Premarin. And, there was 18 million women in America, 40% of all women in America, as you know so well, that were on hormone treatment, primarily with Premarin and Prempro. And there was a reduced risk with Premarin. The risk that halted the study was 1.26 relative risk with Prempro. The Premarin plus an artificial progestin, 1.26. But in the article, they said, but this was statistically insignificant. What statistical insignificance means in medicine is there is no conclusions that can be drawn.
Right.
Zero. That article never should have been published. There was a lot of clamor around, hey, listen, we can't publish this thing. This is statistically insignificant. But the choice was overridden on the original committee. Well, that original study was followed up. Those women were followed up for 18 years. And in 2017, the same committee that published the same article in the Women's Health Initiative in the same Journal of the American Medical Association, came out with a study that said after 18 years of follow-up, there is no risk for breast cancer, heart attack, and stroke with Premarin and Prempro.
Right.
In last month's journal called Cancer, there's a medical journal called Cancer. And this particular journal is edited by a medical doctor who's a world expert in breast cancer. And he's an oncologist. That means he's a cancer specialist. And he was given the honor and privilege of being the chief editor for a whole journal. And once again, Dr. Avram Blooming, with the help of Dr. Carol Tavris, is now expressed in scientific journals many articles, including 2 articles by himself, that show that the preponderance of evidence by far is that women who are treated with hormones are at less risk. Breast cancer, heart attack, and stroke. And that the information that's prevalent out there is wrong. and based on rogue studies that have many faults to them.
Quickly, may I ask, can anybody get a hold of that
You,
journal?
you can. It's a little costly. It's a little pricey,
Right, but you don't have to be a
but
doctor.
you. Well, I'm not sure. I'm a doctor, and I go on the website, and I can give you the link, Carolyn, and you can post it, and you can go in and buy the articles. They're like $50 a piece, so you can be selective. But the fast track to understanding this subject is purchasing the book Estrogen Matters by Avram Blooming and Carol Tavris, where they've done just a phenomenal job of summarizing. Now, this thing is so up to date. I didn't learn a lot more, but I did learn some things. Dr. Blooming is a world expert on the medical literature as well. So his view of the medical literature is just wonderful. It's you get a chance to really get the overview of all the medical literature, not cherry pick an article or two, which will really throw you off.
Yeah,
So if you see my head turning, it's because I'm looking up this article so I can give it to you to post.
thank you. He is a bright man, and Carol Tavris is woo
Yeah,
incredible.
yeah. So bear with me just a minute.
No, no problem.
So I don't know why the general public could not. I'm typing this into the chat. You can pick it up there, right, Carolyn?
I have the private chat, so it'll come. Yeah. Oh, there it is. Yep, got it.
So anyone who wants to purchase this, and there's a lot of articles there, so we're talking about a good expenditure. I've been purchasing them one by one by one. Here's the thing to know in general, though. We're all at risk for thousands of diagnoses. Many of them not good.
No.
They're a piece of work. Some of them severe.
Yeah.
We're all at risk for cancers, hundreds of them. Then as a male, I'm at relative risk, greater relative risk for developing prostate cancer than I am for other cancers. There are reasons for that. They're environmental, they're dietary, they're exercise. There's reasons why we get these illnesses. Women are at increased risk for relative risk for breast cancer. There's reasons why that's so. But given all those reasons, women are at less risk and men are at less risk if we're treated with hormones than if we're not. And the best science is based on women getting treated with Premarin and Prempro. We're at less risk. Women who have the BRCA mutation, who definitely have increased risk for breast cancer and ovarian cancer, they definitely do. They're at increased risk genetically for it. They're at less risk if they're treated with hormones. Less risk for developing cancer if they're treated with hormones. I'm not making any recommendations how an individual woman with a BRCA mutation should behave.
No, of course.
Many choose a radical mastectomy. There's nothing. Everyone must face the details who has the BRCA mutation and make their own decisions. I know this woman did not have the BRCA mutation, but she's got a first-degree relative there that had some genetic issues there. So, she wants to pause and ponder.
Yeah.
Women who've had breast cancer and had that breast cancer properly treated have a relatively increased risk of recurrence than a woman who's never had breast cancer has in getting breast cancer. Women who have had a breast cancer, had that breast cancer properly treated, and had that increased relative risk, are actually at less risk if they're treated with hormones for recurrence than if they're not. This is the science. Doesn't mean we're not at risk, but the science is women who are treated with hormones, whether they have the BRCA mutation, whether they have a first-degree relative. Having a first-degree relative, that is only one of thousands and thousands of vulnerabilities that we have. As I like to illustrate this, to understand how a person gets ill, I like to think of it this way. Let's pretend that a videographer took a video of you from the time you were a fertilized egg in your mom's womb till now, 24/7. And that they had a magic editing button that they could press that would delete all the good stuff in your life, all the good food choices you make, all that good exercise you got, all the freedom from toxic exposure that you chose, all the great ways that you responded to the stress of life. And they deleted all that good stuff. What would remain would be indiscretions of what you ate, the toxins you were exposed to, the exercise you did or didn't do, you did to excess or you didn't do, and the dysfunctional response to stress that was way overblown triggered the full fight or flight biology that suppressed your immune system, among other things. There we would see the story how people develop serious illness. And there are thousands and thousands of this in a midlife person, if we were to show that video. There's thousands of assaults on our physical body that diminish our energy and our health. That's where the origin is. We can have genetic propensities to develop diabetes, but our primary genetic propensity is for health. We can have genetic propensities to develop because there's cancer in our family, but our primary genetic propensity is for health. In order to get not health, we have to do a bunch of stuff that is not okay for our bodies and our minds, our lives, and our souls. And then, there's even the mysterious. I listed 4 possible causes: nutrition, toxicity, exercise, and dysfunctional response to stress. There's a 5th one. It's unexplainable. It's very hard to explain by ordinary means. A couple that has a baby that lives only 5 weeks and passes away. These things are not explainable by normal means. So there are causes that are tough to explain. So you got to put all this in context. And having a first-degree relative, it's still like for a woman who has a first-degree relative, like a mom who had breast cancer, she still only has a 1 in 12 increased propensity to get cancer. Her primary, 11 or 12 of these women are not going to get cancer. So medicine has got some details and some complexities to it. But what I recommend is that this woman purchases the book Estrogen Matters, because Dr. Blooming goes into this in great detail. This even transcends the estrogen receptor site positivity thing. People in their minds, they think, oh God, I had an estrogen receptor site. I guess certainly I can't take it. Wrong. That's not how it plays out. This is very unclear. The evidence does not correlate. Just because you had an estrogen receptor site doesn't mean you can't take estrogen.
Well, I know that you discussed this at length with this woman, and she's amazing. And now I've gotten into all that because I did have breast cancer twice, so it's of interest to me. Indeed, I didn't even know what a receptor site was, till like way back. But yeah. Yeah. Thank you for saying that, because I think that it makes us feel more secure, and especially when it comes from you, a doctor of 50 years who trained the very first 6 nurse practitioners on the planet. I haven't given you a proper introduction in a long time, Dr. Rosensweet, but I will. I have other questions, but a question just came up that if you don't mind, I'd like to ask it. Do you mind?
But I think we should stick with the questions first that
Okay.
people took the time to
Yeah.
send
Okay. Okay.
you,
Okay.
and the
You're right.
challenges with that particular question. So you can ask that next time, maybe.
Okay. Um, okay, so this is my third question. I'm in surgical menopause. I've been on estrogen patches and I'm now just starting testosterone cream, zero point 0.5 milligrams. Is there a good starting dose for testosterone? I was taking it daily and I'm wondering if that might be too high of a dose. Does testosterone have a half life? My doctor said if I'm uncomfortable, I could take it every other day if I like. But will I still get the benefits from the testosterone? Thank you.
Well, the thing that is fabulous is that you're taking testosterone. And in the world of testosterone, this is not a huge dose by any means. But the process of dialing in every hormone for each woman, we're talking ovarian hormones, we're talking 4 hormones, we're talking the estrogens, progesterone, testosterone, and DHEA. That process varies individual to individual. So I can't tell you with you as an individual, but you're starting nice and low there. And the method always becomes you start low and move slowly and gradually increase it, as we describe in great detail in the book, Happy Healthy Hormones, which you can download for free, which I'd recommend that you do.
It's at the very, very top of the group, by the way, for everybody.
These hormones are powerful, and in most instances, if you take too little, you're going to have symptoms of too little. If you take too much, you're going to have symptoms of too much. So, not a lot of women who take testosterone, if they go into overdose, they're not going to like it.
Mm,
They're going to get testosterone-ish. They're going to get grouchy and irritable and want to punch everyone out that they see. They're going to develop oily skin and acne. They're going to get hair on their mustache area and chin. This is from excessive testosterone in a woman. You can get irritable. So, not many women go over the top with testosterone. But you're doing fine. And half life, this is a scientific detail that you don't have to know. It's relevant, but what you need to know is that you can say, if you get the dose correct for your body,
right.
and women vary. One woman could need this much, another woman could need 3 times that much. And they're both normal and they both need these differences, and everyone in between. If you get the dose right, half life's not going to play into it. You're going to be taking the right amount, and I highly recommend that you be treated daily with that. So you're working, you're efforting to see if you can find your optimal daily dose. And I happen to have a calculator here, and you're on, let's see, she says she's taking a half a milligram a day. I'm totally assuming that half milligram you're taking is topical. It's in a cream or gel or oils. You're not swallowing a half a milligram of testosterone, because we do not want to take testosterone orally. Zero. No woman, no man should be taking testosterone by mouth. You can't even get it, I don't think, anymore. So I'm assuming that half a milligram is oral. I'm sorry, topical. Excuse me, topical. You're
That's
applying it to
right.
your skin. You're applying it to your skin or mucous membranes. This is a low dose, half a milligram a day. It doesn't mean that's not your perfect dose, but I wouldn't think of yet taking it every other day. I would start at a half milligram and gradually increase. And we have women that are applying to their skin, just for example, relatively common, 4 milligrams a day. It doesn't matter so much what milligrams you apply, it matters what you absorb, and it matters what your individual need is. Clinically, this is not a problem, as we describe it in our book. we start low and gradually increase until you feel the benefits, and you don't go over the top to where you're starting to get symptoms of too much.
Right.
So
Yeah,
in
you
the
don't
book,
have to.
we have a rendition of this card which lists symptoms of too little and too much testosterone. I don't know if you can see that.
Yeah, I post it and it keeps going down,
Perfect.
down, down, but I keep
Yeah,
posting it.
he might post it again,
I am happy
but
to do.
these hormones are so powerful that the great news is they're gonna speak loudly to us as to when is it too little and when is it too much. Not perfectly, so we always go through a process of a woman under guidance, under supervision, finds her optimal dose, and then one day she says, "Wow, I think I found my right dose." I did take a little extra testosterone for a week, but I started getting irritable. So I backed it down. Now I think I'm on my perfect dose. My libido's increased, my mood is increased, my natural aggression has returned. I like this dose. And then we say, great, we're going to test you. We're going to confirm this with a 24-hour urine hormone test. And so it's a process of doing all those steps. You don't leave any of them out, you get it right for your lifetime,
Right.
pretty much. Because once you dial it in, it may take you some time during your first year of figuring out these hormones with your provider to dial it in, no problem. But once you get it dialed in, it changes very little year to year. And we check in with you annually, so we
It's
find out
amazing.
you're a little over the top or a little too little. That final 24-hour urine hormone test is really important because we want to optimize that testosterone. Because number one, testosterone is a human hormone. It is not a male hormone. Estrogen is a human hormone. It's not a female hormone. Now, men have a lot less estrogen than women do. That's for sure. But men need a certain amount of estrogen. And if they don't, there's problems. It's low compared to a woman, but they need a certain amount. Women need a certain amount of testosterone. If it's low, there's guaranteed problems. There's more testosterone in a woman's body than there is estradiol, the most potent estrogen, milligram per milligram. Certainly, nature had a reason for that. Yeah, because it's crucial for maintaining your muscles. And those who lose testosterone lose their muscles. It's the bane of the elderly, muscle loss, called sarcopenia. And it's the reason why women get into canes, then walkers, then wheelchairs, and that's quite a moment right there. That's makes a woman vulnerable for assisted living. And when she loses the muscle that holds up her bladder and uterus, that coupled with the vaginal atrophy from loss of
Ugh.
estrogen is a recipe for adult diapers. And you put adult diapers in with a wheelchair, and these are when women very often have to leave their home for extended care.
Oh, it's so sad.
So why I'm leaning on this is, as a physician, I have this long range view. Someone's 60 and they say, I'm fine. I'm just a little weaker than I used to be. Yeah, well, how are you going to be at 70, 80, or 90? As you and I have said so many times, Carolyn, your life is going to matter as much to you when you're 90 as it is 60 right now. And you want to have the long range view of how to prevent what happens to so many people, because so many people, God bless assisted living facilities and nursing homes. Oh my God, they're such a gift that we have. But many women and men would like to not do that. One of your biggest chances of not doing that is getting these hormones right.
That's right.
There's a tremendously high percentage of women who are in nursing homes and assisted living facilities simply because they don't have enough hormones. Lost their muscles, lost their cognition, adult diapers,
I mean,
wheel.
it's like you and I have said, you go into the store and the whole aisle
There's
is
a lot of real
devoted.
estate taken up by adult diapers.
Yeah.
And there's reasons for that, and most of them are hormonal. So I'm mentioning this because getting testosterone right really, really matters. And you're on your way. My God, your doctor prescribed testosterone. This is an advanced doctor. Advanced.
Absolutely. Yeah.
And we'd be delighted to talk to your doctor because your doctor has got good ideas. and we may be able to, maybe your doctor doesn't need any assistance, although taking it every other day in that low dose makes me think that maybe your doctor could benefit by some additional training in this area. But you've got an advanced physician, because many physicians, and the general word on the street is, don't take testosterone, women.
Correct.
That's criminal to have ideas like that out there. That's negative for women. I was about to use a harsher word because I don't think the intent is misogynistic, but the outcome is to suggest to a woman that she doesn't need testosterone. It turns out to be a misogynistic event, whether the intent was misogynistic or not. Women need
Correct.
testosterone just like they need estrogen and progesterone. So,
It,
and you're well on your way. That's the great news. This particular questioner, she's got someone who understands a lot more about hormones than people who haven't specialized in this. And so, good going. Just take it further. Take a look at, maybe you post that card again of testosterone
I
symptoms.
no, yeah, I will. Yeah, I can't tell you how fast that thing goes down. But I'm happy to do that, of course.
Yeah, because
Um,
what we do in our practice is we optimize testosterone. And by optimization, I mean we jack a woman's testosterone up until she gets symptoms of overdose in many instances. Then we back her down because we want her to ride at a level of testosterone that's going to serve her health and serve her body. So we don't just do a little bit, we do an optimal amount. So she preserves her muscles and preserves her bladder. Duh. Not to mention the other very important beneficial effects of testosterone on mood, stuff like that. Good
yeah,
going that you're on testosterone. That's what I have to say. And to all the women out there who are not on testosterone, get thee to a provider who understands that testosterone is as important as other hormones are, and make sure that you're getting compounded bioidentical testosterone at the right dose.
thank you. This question, well, she asks, how much progesterone is in one drop of the menopause method oil?
8.7 milligrams. There
Okay.
you go. Progesterone, 200 milligrams per milliliter. Here it is. Ta-da. And we've done very careful calibrations of this. And one drop that comes out of that bottle contains 8.7 milligrams
Wow.
progesterone.
Very nice. Well, thank you for that. Um, and well, have you ever heard of hormones? This woman said her doctor gave her a hormone pill. I'm not sure which kind of hormone pill, though I have an idea. Um, uh, Causing fainting spells. She went to the emergency room, had all the whole workup, blah, blah, blah. And the physician there attributed this fainting spell to her hormone pill and the possible side effects of it. The emergency room doctor who was on call said to only take it in the event that she starts getting hot flashes and night sweats. And she's wondering your thoughts on that.
In 28 years of treating women in menopause with compounded bioidentical hormones, not by pill, maybe progesterone by capsules, but that's not what they're referring to.
Mm-mm, I don't think so.
I've never run into this. Now, we know that oral hormones, or that would probably include hormones in general, like some women who went on the birth control pill got dizzy, got lightheaded. Often it was temporary, but it definitely happened. So once you get a symptom like that, that's what I'm saying. The emergency room doctor could be correct that it was coming from the oral hormones she was taking. But when you get a symptom like that, something's wrong. The dose is wrong, the delivery method is wrong. It doesn't mean you don't need hormones. For estrogen and testosterone, we never give it by mouth, or with very, very rare exceptions. There's something that needs to be sorted out, but you don't throw out the baby with the bathwater. You don't take it every other day or only when you get symptoms. That's not the proper approach. I understand why the emergency room doctor would say that, because the emergency room doctor knows very well that although a rare complication of hormones, a rare side effect, you can get dizzy. So you just go back to the drawing board and you figure out a process that where you get it right. Because if you're getting a symptom like getting dizzy, something's not right.
Yeah,
Duh.
right.
Now, my guess, it starts with the oral hormone and a process that wasn't properly done. Because if a woman hasn't seen hormones for a while, we start with low doses and we gradually increase, getting her body used to it. So getting dizzy is an adverse reaction that probably comes from overdose or wrong route of administration. So you just do what we do all the time. We refigure out what's the next right step. Oh, you got dizzy? Oh, look at that. You were on oral estrogen. Well, why don't we do estrogen properly, which is topically biased? We'll start low and we'll gradually increase. And I think that's one of the reasons why I've never run into that complication. So we start low with bias topically, and we just haven't gotten into challenges with it. As far as dizziness goes, sometimes the processes have things that we've got to sort out, iron out, customize, individualize. But there's always a way. I mean, you had hormones when you were young, therefore there's a path to replenishing them that is going to be successful. End of story. Sometimes that process of getting them successful can take longer than people would think they should do. Should. There ain't no should on this planet. You just take our time and we figure it out. Speaking of time,
That word goes along with hard stop, right? You
and
have a hard stop.
you're going to announce the new format because of multitude of commitments.
Well, I put it out there, but I will say it again. We will be doing our interviews on Tuesdays now only, not on Thursdays. But we will be doing them on Tuesdays, and we will get to the questions. And I have these, and I will copy them, and I will ask them next Tuesday. And in the interim, we are all going to miss our dear David Rosensweet for the entire week. I find that a huge jip. So I'm going to wish you an amazing, amazing week. Thank you, everybody, for coming up. You know where to reach me on the ins and outs of Menopause with David Rosensweet, MD. Just got back from London. The Queen whispered to me that he's a sir, but don't tell anybody. Right? Right. Anyway, thank you, Dr. Rosensweet, for today very, very much. It's good to see you, as
You
always.
too, Carolyn. Good to see
Thank
you.
you.
Welcome back to the US of A.
Oh my God, I'm walking into walls. It's hard to like acclimate to that time change. You get
Yes, it is. Yeah.
it is. Wait. So I'm gonna wish you well, I'll bid you adieu. See you a week from now. I'll get to the questions. Wish everybody a fabulous week. And we'll see you on Tuesday.
Good to see you, Carolyn. See you all
Always
next.
good to see you.
Bye bye.
Bye.